And regarding this dopaminergic system, so far you know about the substantia nigra. That's what we discussed. So you have this structure in the midbrain that has two components, pars compacta and pars reticularis. And the pars compacta, those are dopaminergic neurons that degenerate in Parkinson's disease. But there is another area in the midbrain which is rich in dopaminergic neuron. Right now, this is a super hot topic, guys, in neuroscience and neurology, because 2 weeks ago they published a paper in which they showed that this area has a crucial role in Alzheimer. That's kind of new because, dopamine was never linked that badly to Alzheimer. But, this is really, and, since we can modulate this dopaminergic projection with drugs and everything, that potentially has a huge impact. So I want to tell you a little bit about this circuit and how this area control cortex, and then we will review those horizontal eye movement. So you remember from last week that substantia nigra, it's localized pretty much in here, and you have the two components. But if you go right here, in the anterior portion of the midbrain, almost in the area between the two cerebral peduncles, that's the area I'm talking about. It's called VTA, or ventral tegmental area. It's easy to remember because ventral, anterior in this case, tegmental because it's in the tegmentum area. Also in here you have dopamine and dopaminergic projection. So dopaminergic projection for substantia nigra project to striatum and basal ganglia. And they have that role in movement control, as I told you last week. What about this VTA area? This VTA area projects to another component of basal ganglia. You remember we have the nucleus accumbens that you see mostly in the anterior cross section. And so that's the main side of projection, but not the only one. It has also massive projection to prefrontal cortex and other area of the limbic system, such as amygdala, hippocampus, and hypothalamus. So this area is extremely important because the projection to nucleus accumbens, as I told you, are important for a system called reward system. Malfunctioning of this reward system, it's linked to drug addiction. So the reward system is also called mesocortical limbic system, and but we will discuss more about this. But it's a huge impact in drug addiction. Okay, so this is you release dopamine in this pathway if you do something that gives you pleasure, and our brain is wired in this way. If we like something, we want more. Of course, a pathological expression of this kind of behavior, if you want, is drug addiction, but also food addiction and many other pathologies that are extremely important, and many other diseases, especially in psychiatry. Okay, so remember, ventral tegmental area, projection to the accumbens, and we will see in the slides where are those nuclei. Prefrontal cortex, and remember, the prefrontal cortex is the CEO of your brain. So it's very important that the interplay between those areas, because when you have something, you are in front of this huge, beautiful chocolate cake. You have just one little piece, and then you keep on going and everything. So the ventral tegmental area and the accumbens send you the message, keep on going. Prefrontal cortex send the message, stop, because it's damaging your health. So the interplay between the prefrontal cortex, accumbens, and ventral tegmental area, it's very important in those addictive behaviors. Okay, so remember, VTA, mesocortical limbic dopaminergic symptom, I like, I want. Okay, you have mostly dopamine in those pathways, but there are also some fiber that are GABAergic and glutamatergic. And I will show how important are that, okay? So this is the series of connection. VTA, remember, in the anterior portion of midbrain, nucleus accumbens, the ventral striatum is the nucleus accumbens. Okay, you have also this definition, ventral and dorsal striatum, but just remember nucleus accumbens, and then we have prefrontal cortex and limbic system. Why limbic system and hypothalamus and everything? Because when we like something, we receive pleasure. So it means that you have activation of the autonomic nervous system in other area that make you feel good. That's why, unfortunately, drug addiction is really such an important issue. You will see, you will witness, guys, in your practice, both group actually, a huge epidemic that we're facing right now. That is the opioid epidemic, and in general, painkiller. I I published just a couple of months ago a paper on refractory pain with a new treatment, and those patients they were very severe patients, but they were patient taking 158 Aleve each week. Can you imagine what this treatment would do to the kidney of those and just this is just the end said. So imagine most of them they were taking opioids at the same time. So and also the PT they will treat pain management will be really one of the main scope of practice for the PT group, and all the modality that they are going to use, they're mostly they will have an amazing effect at least on reducing the amount of those pain medication. So this is actually extremely important in this addiction. Has you will find actual abnormality of this pathway also in patients affected by chronic pain. Okay, so remember this. So ventral tegmental area, you release dopamine. The system is called reward system. I like, I want more. That's a reward system. It sends projection to area that regulate motivation, emotion, drug seeking behavior, and also prefrontal cortex, which is the executive functioning system. So you will have decision making. Okay, so if you have a dysregulation of this system, okay, so you will have the nucleus accumbens and the prefrontal cortex. If there is an increased activity of the nucleus accumbens, you will have a bad decision and this addictive behavior. Instead, if you have an increased activity in prefrontal, that's you will have the opposite. So that's why now, as you know, we have as a treatment. Now we can use a technique called transcranial magnetic stimulation. You can stimulate, zap the brain with this electricity. So the most modern way to treat drug addiction, including addiction to painkiller, is to enhance the activity of prefrontal cortex with this brain stimulation. So you change the balance between those activities. So remember all those things because they are all crucial in this kind of behavior. But this system, it's also regulate. It's important in another form of learning. It is emotional learning, and we will discuss actually next week when we'll do actually the limbic system. And also, this system is also abnormal in patients with schizophrenia. So we will use a drug that are anti-dopaminergic to treat schizophrenia because of this. So we want to block the overactivity of this system. That's why we give anti-dopaminergic drug. And here a little bit of summary of what we find in the schizophrenia brain, which is really a little summary, guys. Schizophrenia is one of the most complex. You have to consider that a schizophrenic patient has a wide range of behavior. from being simply a little anxious and agitated to behave like a serial killer. So there is this wide spectrum of behavior that you find in those patients. So it's really actually extremely complex. There's not a single area that we know that is dysfunctional. We have a multiple network, and the complexity, this is a chronic condition, very serious. Okay, so just to give you, to complete this dopaminergic regulation that we did. So beside dopamine equal Parkinson, basal ganglia, remember there is a dopaminergic pathway equal drug addiction, and remember the circuit, VTA, accumbens, and prefrontal cortex, balance between accumbens and prefrontal cortex. It prevails the accumbens, you have addictive behavior, and the other way around with cortex. This, beside addiction, this pathway very important for schizophrenia, and drug that you will use to treat abnormal behavior. Also in Alzheimer, guys. In patients with Alzheimer, after few years, when the disease becomes more severe, you have also abnormality of this system. The patient behave really oddly, difficult to manage them. Some of them, they are aggressive and so on. So in addition to the memory issue, you have the behavioral. So you will use in those patients the same drug that you will use in patients with schizophrenia. Those are anti-dopaminergic drugs because dopamine is the key neurotransmitter in all this circuit. Okay, let's get back to horizontal eye movement, guys. So why I put those two things in the same presentation? Because as I told you, those horizontal movements are regulated by dopamine. So remember I mentioned already that we have, when we did those lesion of the oculomotor, of the ocular, of the nerve that control ocular movement, we did one by one. Then we did the VOR, vestibulo-ocular reflex, that was a reflex that required horizontal movement. Now I want to go more deeper into the circuit that regulate horizontal movement. Those movements can be abnormal if you damage the area of the brain that control horizontal movement, but also are abnormal if you have those diseases that will alter the concentration of dopamine. So if you have a patient with Parkinson, you remember the main sign of Parkinson is bradykinesia, slowness of movement, but that apply also to horizontal movement. The horizontal movement that we call saccades, and I will tell you more, they will be bradykinetic. So when you do your neuro exam, you have to check also for the ocular movement, and when you do a rehabilitative program, you have to consider to do rehabilitation also of this system, not just hand, torso, and lower extremity, because it's crucial for balance maintenance. The center that control those movements are in the brainstem, but it's a large network from cortex, although the key center are in the brainstem. So if you have a disease that affects brainstem, very likely you will find signs that are crucial, very important signs that clinically you will see all the time. So you will see those movements very often in patients with multiple sclerosis. Extremely common abnormality because plaques tends to localize everywhere, and as you know, you have all those pathways in the brainstem. So it means lots of white matter that, as you know, it's the target. So abnormality of those movements, it's very common in multiple sclerosis. You know that is a disorder of central myelin, oligodendroglia, can affect, each area of the brain, and it's an inflammatory, and inflammation lead to secondary axonal degeneration. So those patients, they tend to accumulate disability, attack after attack. So you will see, so if you do an histological preparation, you will see the inflammatory infiltration. So those antibody will bind the myelin, and you will have demyelination, and then you have a secondary axonal loss. So clearly, already when you have inflammation and edema, you already have neurologic sign. Those signs are even more pronounced if you damage the myelin, because remember, myelin control and regulate the velocity of action potential. So though, even if you don't kill the axon, if they are myelinated, they don't work in a physiologic way. Of course, after several attacks, you will also damage the axon. So that's why those patients, they will, in some of them, there will be projection, and, in a few years, they will be unfortunately on a wheelchair. So it's really that projection come from this axonal loss that will accumulate. And that's how it look like. And we will go over to those slides later on. Look at all these dots here. In here you have, it was supposed to be white, because here you have white matter. It's at the subcortical level. That's the target, white matter, myelin. So that's where you see, so you see the ventricle and the surrounding area. It's in this different, using Luxol you can see much better. Look at those dots here. Those are plaques, area in which you have demyelination. This is a coronal section. You already know this. You can interpret yourself this area. You remember the ventricle, then you have the nucleus caudate, the caudate nucleus, which is very close to that. Then you have the putamen, and you have the pallidum that has two components, internal and external. Then you have this structure here called claustrum, and here you have insula lobe. That's what you see in cross-section and what you will see actually in those slides. So that's the area rich in white matter where you have most commonly those plaques, but those they can be also in the brainstem. Don't forget that the fiber, they come from cortex. So even if you don't damage cortex, but those fibers are damaged, so the patient will have trouble walking if you damage corticospinal tract and any other of those tracts that I discussed before. You know that the disease, the most common form of this condition, it's called relapsing remitting. So you have attack, the attack resolve, it leaves some disability. Unfortunately, you will have a new attack, several new attacks. Each one will give some kind of disability. So after a few years, there will be a burden of disability that will show clinically. Some forms are very aggressive. They are called progressive. But usually, that's the kind of natural history. So you have a subclinical phase in which there is just inflammation. Then the onset usually it's with an attack of a single organ. Usually it can be cerebellum, so you have one of the syndrome we discussed. It can be spinal cord, one of the syndrome that we discussed, or it can be optic nerve, so you will have total blindness. Or you can have a combination if you have a widespread location of those plaques. But usually it's one organ, it's damaged, it's dramatic, you give steroid as a treatment because you have inflammation, so you want to block that, and within a week the patient will recover. Of course, you will have relapsing remitting phase, and in some cases, after a few years of relapsing remitting, it becomes progressive. That's where the disability become really very, very remarkable. Some cases, unfortunately, they are very, very serious, and they're very, very fast. So the progression, it can be really, really fast in some cases. We have now very good drug actually to treat it. But don't forget that you accumulate the disability, you accumulate those plaques, they are like scar in the brain. You damage, then you repair. So they leave scar, these, remyelination processes. So those patients will develop also cognitive deficit over the year because you damage cognitive fiber. So beside movement and a massive issue with bowel and bladder, especially bladder physiology because of the spinal cord lesion, they will have also cognitive issue as well. But clinical, as I told you, very often in those patients, you will find abnormality of those horizontal movement. Remember the movement that we discussed so far when we did all those six muscle and the three different cranial nerves that control them. We have horizontal movement, and those are abduction away from the nose and adduction toward the nose. Then you have vertical movement in which the eye bulb moves up or down, elevation and depression. And then we have also torsional movement along an anteroposterior axis. So the ocular bulb can rotate toward the nose or externally. So you will have intorsion, rotation toward the nose, and extorsion toward the ear. Those are all the movements that we have. And each one, when you review them, you will see each cranial nerve will control a muscle, and those muscles, they will do one of those movements. Okay? And you have the third that will control some of those movements. Remember, levator palpebrae superioris, which is, that's why those patients will have ptosis if you have damages. Then superior rectus, inferior, medial, and inferior oblique. Then you have the trochlear, only one, superior oblique. And then you have the abducent, only one, lateral rectus for abduction. Those are the function. Remember one thing, guys, if you have a lesion of those nerve, all those muscles function like elastic band. So if I have, imagine this is the bulb, and then I have all those muscles. If I damage this muscle here, those one will take over. So when you look at the patient, if there is a pulse, there will be a deviation toward the activity of the healthy side. So when you review those lesions and you find that in the handout, remember, in primary position, when you look at the patient, each one of those nerve pulses will have a pattern. So there is the eye deviate in different position. Then, of course, if you challenge the patient to follow your finger, you will see the muscle that is paralyzed. But in primary position, you already have a pattern. Okay, I can put some question regarding the primary position deficit in a pulse of those nerve, or which muscle, of course, is affected by the paralysis. Okay, remember, and it's in your handout. Each one of most of those muscles we discussed only one function: elevation, abduction, and everything. But for the oblique muscle, you have to consider a secondary function. The superior oblique depress the eye and also intort. The inferior, elevation and extorsion. So for only those two, I want primary and secondary position. Also, the other one has secondary position, but I don't want you to remember that because it's very complex and it's for neuro-ophthalmologists, not for this course. But for those two, yes, because it's very simple, just elevation, depression, and then intorsion and extorsion. Okay, so that's regarding each single muscle, the neural control, and so on. But as I told you, we have also conjugate movement. So you can move both eye on a different plane. It can be horizontal or vertical. I want you to skip the vertical conjugate movement and to focus only on horizontal. If you consider those horizontal movements, you have two different kinds of those movements. One kind of movement is called smooth pursuit movement. The smooth pursuit movement, you still move both eyes, but when you look at the moving target. So if you look at my finger, and then without moving your head, just the eye, you follow me moving, so you are It's a slow movement that follows a moving target. That's what is a smooth pursuit. Okay? Instead, if I stand in front of you, I ask you to look first at my nose and then to switch from one finger to another. First this, this. So your eye movement needs to switch from one target to another. Those are saccades. Okay? So saccade, switching from one target to another on the horizontal plane in this case, smooth pursuit instead, following a moving target on this. So one is very fast, the other one is really slow movement. They have a different circuit, so they both can be impaired in different disease that will damage those uh, um, those uh, um, those area. Saccades are particularly important, guys, because as I told you, in many diseases you have impairment, including Parkinson and cerebellum control also saccades. As you can have dysmetria. If you do this, what I did so far in a patient with cerebellum, you remember when we had the dysmetria, they cannot reach the target and they do fast point? There will be also dysmetric saccades. So you will see that one eye will go way above your target when they try to switch from one to another. So they are muscle. So the same thing that happened to arm and leg, they will happen also to ocular movement. So don't forget when you test your patient, just consider also the ocular movement. In those diseases, you will find the same pattern. Bradykinesia of the saccades in Parkinson and dysmetria of saccades in patients with cerebellar lesion. Let's talk about the circuit, guys. You already know the area of the brain that controls those saccades. We did probably on the first lecture. You remember the frontal eye field. That was an area in frontal lobe anterior to motor cortex. Is some sort of specialized motor cortex for saccades. But not that. The network is really huge. That's why you have abnormality of the saccade in many diseases. Reticular formation is important. The superior colliculus is a key structure. Frontal eye field, as I told you, in frontal lobe. Posterior parietal cortex controls saccade. Supplementary eye field, that is a little area close by, has also a function. Substantia nigra, I told you right now, those dopaminergic regulation, and also caudate, basal ganglia in general. So you see how many diseases, and cerebellum is out of this picture because I mean, it's so imagine virtually in so many diseases of the lesion of the brain, you will have these saccades that are affected. That's why, guys, clinically, this is another standard question that you're gonna find all the time because clinical is a huge impact. You find abnormality in so many patients, so you cannot skip. So those are all the area. Let's see now how, let's build a circuit that controls those saccades when I jump from one target to another on horizontal plane. Okay. I say horizontal plane, guys. So if I move my eye in this position, on this eye, I will activate the lateral rectus muscle, 6th cranial nerve. On this eye, I will activate the medial, 3rd cranial nerve. Okay? So in order to make horizontal movement, whichever I need to do, I need to activate 3rd and 6th cranial nerve. You with me? Perfect. Remember where those nerves are located. The 3rd cranial nerve is in the midbrain, and the 6th cranial nerve is in the pons. So we need something that connects those two nuclei, which you already know. It's a tract that is called MLF, medial longitudinal fasciculus. Okay, so the circuit that you're going to build is going to affect those two nuclei and the medial longitudinal fasciculus. It is rather simple. So everything starts in frontal lobe. okay? Because you have the frontal eye field. This is the most important area that controls saccades. They're all important, but this is the most important. So you will have a neuron that will reach brainstem like corticospinal, guys. Everything starts in there. We're still talking about movement. So from frontal eye field, this neuron will reach the brainstem, an area of the brainstem which is called paramedian pontine reticular formation. So they reach pons, PPRF. Okay, difficult name, but very, very simple. So it's not right in the middle, that's why paramedial. It's a reticular, part of the reticular formation, and it's in the pons. Okay, so those this axon has to reach this area in the pons, PPRF. Another neuron will reach the abducent nucleus, which is in the pons, and then through the activity of the medial longitudinal fasciculus will reach the nucleus of the third cranial nerve. So in this way, at the same time, you will activate the sixth cranial nerve on one eye and the third on the other one. So this control is contralateral. So if I activate the frontal eye field on this side, I will move my eyes in the opposite direction. So it's a contralateral control. This is huge because frontal lobe is often damaged in stroke. So your patient will have a damage of motor cortex, which is right there, so paralysis, but at the same time you will have deviation of those eye. Let's go over again to this circuit. Okay, so remember contralateral regulation. The key player are the sixth cranial nerve and the third cranial nerve. And remember, it's a contralateral. So if you consider the right brain, the eye will move on the opposite side. Okay? So frontal eye field, first neuron, input to the saccade center and also superior colliculus, put a note, SC superior colliculus, then this area in the pons, PPRF, and from here, sixth cranial nerve, medial longitudinal fasciculus, third cranial nerve, movement of the eye in the opposite position. It's clear, this circuit, guys? For everybody? Okay. So you can damage the brainstem, where you have the area that controls saccade, PPRF. Okay? What are you going to see clinically? The patient cannot move, they will have problem with saccades. There is a specific sign, which is a correlate of the lesion of the medial longitudinal fasciculus that you find in almost all patients with multiple sclerosis. It's called internuclear ophthalmoplegia. So you will have a problem with movement, okay? So you will have a problem with adduction if you check clinically, and the eye that try to abduct will have a nystagmus, those oscillation. Remember, guys, MLF control the connection between the sixth cranial nerve and the third cranial nerve. Sixth cranial nerve, abduction, lateral movement. Okay? Instead, third cranial nerve, adduction. So clinically, you will see deficit of the medial rectus, so one eye cannot move toward the nose. The other eyes, when attempt to move laterally, will have a burst and get back to the original position, nystagmus. Okay? This, if you have this sign that you will see clinically, It's very, very simple, guys, to test that clinically. So we simply stand in front of the patient and you just move your finger. So if I move in this direction, one side has to abduct, the other to abduct. So you will have paralysis of the adduction, and the abduction will have nystagmus and come back on the original position. This is a classical sign of multiple sclerosis or an extremely dangerous brain tumor, which can be localized in the brainstem, a glioma, glioblastoma. You know, this is probably the most dangerous brain tumor, and in general, one of the most aggressive tumor ever. When it's localized in the brainstem, it's really, there's nothing that you can do really in there, and it's unfortunate the patient die within 6 months usually. Those are not rare, unfortunately, but clinically that's what you see very often because you damage right there. And here, look here, this is a patient. If you look at the MRI, look at this white spot. It's in the pons. The damage is between the 6th cranial nerve and 3rd, the MLF, medial longitudinal fasciculus, and you have this pattern. Okay? So you will have ipsilateral horizontal gaze palsy if you have a lesion of the PPRF. Okay? So if you have MLF, you will have the internuclear ophthalmoplegia. If you have a damage of the PPRF, you cannot activate the horizontal saccade, so that the same side will be paralyzed. Okay, the last thing, and we're almost done, guys. As I told you, you can have a stroke. So you damage the frontal eye field. Okay, so let's consider this scenario. So you have the two hemispheres. Okay. Imagine you damage frontal lobe on this side. In here you have motor cortex, so corticospinal tract, that will control movement of the opposite side of the body. So the opposite side will have paralysis. Okay? That's corticospinal. It's still frontal lobe. Okay? Anterior to that, you will have the frontal eye field. So beside the contralateral paralysis, this patient will have abnormal horizontal movement. Those eyes deviate. But which side? They deviate toward the lesion. So if this is the right side, or toward the paralysis, left side. Which side are that? Remember, guys, that the frontal eye field control horizontal saccade in the opposite direction. Okay? So if you have a paralysis on the opposite direction, they will deviate on the same side. So that's the terminology, that the eyes deviate toward the lesion and away from the paralysis that is on the opposite side. Clear, guys? To everybody? Okay. If you have a lesion in the brainstem, instead, the PPRF, they deviate ipsilateral to the lesion, so toward the paralysis. Again, ipsilateral if the lesion is in the medulla, because in the medulla we have the crossing. Okay, so this is the thing that you have to memorize. Okay, if you have a lesion, where is the horizontal deviation? If you have a lesion of the hemisphere, midbrain pons, or medulla, the patient will have a paralysis, so the eye can deviate toward the paralysis or away from that. And remember, it's this contralateral control. Okay, So we're going over first over the coronal section from the anterior pole, frontal lobe, all the way to the posterior one, and then we will do horizontal section. You will have only one sagittal section, and then at the end there are scheme on brain model that are, just for you to visualize better because they are more, enlarged, so you can see better those structure. So if you do a cut anterior in frontal lobe, you will find that's the structure cortex and white matter. So you will have cortex, and then you have the white matter all here, and then the interhemispheric fissure. Same story if you go a cut posterior, the white matter become more evident. Same in here, this is all frontal lobe. So those structures that I mentioned so far, they are in here. Frontal eye field, and if you go posterior, you find also motor cortex. You remember we did on the first lecture all those structures that were in this frontal lobe. If you go a little bit posterior, beside those structures, you start to see a portion of corpus callosum that is the geno of corpus callosum. It has different parts. As you know, corpus callosum connect right and left brain. This area is very important, guys, because there are some diseases in which there is a miscommunication between the right and left side. Don't forget that the corpus callosum can be also damaged. You can have a stroke or a brain tumor. There are brain tumors that affect specifically the corpus callosum, and they are called butterfly tumor. That's how they look like if you do an MRI, like a butterfly right in the middle, and they invade corpus callosum, so you will have a specific disconnection syndrome, which is a specific, those cases are not rare. You can have some children in which there is a lack of development of corpus callosum. So again, disconnection. If you go a little bit posterior, you find a posterior portion of corpus callosum, the corpus callosum here. And then you will start to see the lateral ventricle. Remember, we have the different horn. The frontal horn of the lateral ventricle is also called anterior horn of the lateral ventricle. Interhemispheric fissure, still cortex. Gray matter, white matter. We go a little bit more posterior, the body of corpus callosum, the anterior horn of lateral ventricle, and then you will find, again, remember, the component of basal ganglia attached to the ventricle is the caudate nucleus, which has a different component, head, body, and tail. The head is what you see in here. And then you have this other nucleus, which is called putamen. Okay? You go a little bit more posterior and you find the same thing. On this cross section you cannot see because it's attached in there, but you cannot see very well. On the bottom here you have the nucleus accumbens, but it won't be pointed by an arrow. But that's where you find the nucleus accumbens, in this anterior cross section. And remember, nucleus accumbens, the function is what we described so far. VTA, accumbens, prefrontal cortex, reward system. In here again you have the corpus callosum. In the interhemispheric fissure, remember that we have the cingulate gyrus, which is a gyrus just above the corpus callosum, and the cingulum here. And again you will see head of caudate and putamen, and the accumbens will be right here. You will start to see some vessel here, and you see a portion of the temporal lobe. What you see here, it's the lateral fissure. Remember, on the surface we have the lateral fissure, which is right here. A little bit more posterior, the same thing, cingulate cortex and cingulate gyrus in the middle, body of corpus callosum. You get the head of the caudate. In here it's pointed the accumbens, remember, on the bottom, and then you have the putamen. This area here will be the claustrum. We don't know the function, and if you go all the way lateral, you find the insula lobe, which is deep into the lateral fissure. So you don't see on a surface, you have to separate the lateral fissure, and you see the insula lobe in here. Remember that we have white matter between those nuclei, those capsules. And the internal capsule you find between caudate and putamen. In this cross section is the anterior limb. Don't forget, we have anterior limb and posterior limb. That's how it looks like. So in this anterior cross section you see the anterior limb. In here you have cognitive fibers. In the posterior limb of the internal capsule you have corticospinal tract. You will see the third ventricle in here. Remember that beside the internal capsule we have the external capsule between putamen and claustrum. And then there is another capsule called extreme capsule between claustrum and insula lobe. Okay, so three capsules: internal, external, and extreme. Internal between caudate and putamen, which will have two components, anterior and posterior limb, anterior cognitive fiber, posterior corticospinal tract. Then you have the external capsule between the putamen and the claustrum, and the extreme capsule, claustrum, insula lobe. You already know the function of insula lobe. It's an important part of the limbic system. It will be an area, you remember, some part of a gustatory cortex was there, but also it's a very important function of this area is face recognition. If you look at someone in the face and you do an fMRI, you will activate the insula lobe. Imagine how important is this for social interaction, and also it's important for the emotional component of pain. If you are in pain, chronic pain, severe pain, you will be depressed, you will be sad, you will have a tendency for crying, you don't want to interact with people. All this emotional component of chronic pain is due to neural activity in the insula lobe. And here you see some vessel that we are going to describe later on. You see also portion of the third ventricle. Same story. Here, the same structure, caudate nucleus, anterior limb of the internal capsule, putamen, external capsule, claustrum, body of corpus callosum. Look at this structure here. In between the two hemispheres, you will have the fornix. A portion of fornix called column of fornix. On the bottom here, you see the diencephalon, so optic nerve and optic chiasm. Remember, with the crossing fiber. Still temporal lobe, and in the fissure you see some artery that are very, very important. This is the middle cerebral artery. It's right there. The most common type of stroke that we will have is in here. See, so you find the same structure in multiple slides. So it's super simple, guys, once you visualize them. So corpus callosum, again caudate, putamen, but in here you see the other structure more posterior, the globus pallidum, which will have internal and external portion. Remember that between the right and left ventricle we have a very tiny line of cell which is called septum pellucidum. So you have septum pellucidum and below you have the fornix. You will have the third ventricle here, and this portion of tissue here that you see, it's called anterior commissure. I told you that we have some fiber that connect the right and left brain. The most important one is the corpus callosum, but we have two other structures that connect the right and left. They are called anterior commissure and posterior commissure. The anterior one is right here. If you look, and then you see the insular lobe and everything, all the stuff that we did. Remember the hypothalamus, it's above the chiasm and very close to the third ventricle. You will have the optic tract in here. And focus on the temporal lobe now. In the most anterior portion of temporal lobe, it's called oncus. It's the anterior portion, and inside in the anterior portion you will find the amygdala. Amygdala is a key component of the limbic system. It's the area that controls rage, aggression, sexual behavior, and so on. So it's a very emotional area which is linked to anxiety. Abnormal activity in the amygdala leads to anxiety. And here the same thing, oncus amygdala, pallidum with the two portion, external capsule here, caudate and putamen with the internal capsule, still the anterior limb, septum pellucidum and fornix. Here you have the claustrum. So really, it's over and over the same structure. If you go a little bit more posterior, you find some new structure in here. Again, focus on temporal lobe. You see this structure here? The amygdala, it's no longer in there because it's in the anterior portion of the temporal lobe. So in the anterior portion. If the cut is a little bit more posterior, you will find the other key structure, which is the hippocampus. Hippocampus is the site for learning and memory. Okay, so amygdala anterior, anxiety, face recognition, rage, hippocampus posterior, learning and memory. Then you see the basal ganglia, but look here, between caudate and putamen, now you have the posterior limb of the internal capsule. In here you find corticospinal tract, so motor cortex, all the fibers from motor cortex come together and form the corona radiata, and then they cross in the anterior limb, posterior limb of the internal capsule. A stroke in here will induce contralateral palsy. You have the third ventricle, you have the fornix, the septum pellucidum, you have the hypothalamus, and below in here you see the mammillary body. Remember, mammillary body are connected to the fornix, as you will do when we'll do the lecture on limbic system. This is the area that degenerate in patients with chronic alcoholism. There is a syndrome, remember I mentioned that, it's called Korsakoff syndrome, due to degeneration of those mammillary body. Patients with chronic alcoholism will have dementia and memory loss. At the same time, they have hallucination. They're called zooptic hallucination. So bugs on their skin or animal on the skin, that's the horrifying sensation that they have. And it's due to damage of this area. And you have the third ventricle still there. One thing that I want you to remember and take note of this, as you see in some slide, you will find the different thalamic nuclei, like anterior nucleus of thalamus, dorsomedial. I don't want you to remember the different thalamic nuclei. You have to tell me thalamus. So you don't have to memorize anterior, posterior, dorsomedial, ventromedial, and so on. I want you to tell me thalamus. Okay, it's not important to remember one by one what they are. Okay, in here you can see internal pallidum and external pallidum, much more. You go posterior, you see the same structure. Look at the corticospinal here, how wide it is. And you will go all the way in the brainstem. You have the mammillary body. You will see also a portion of the pons. Remember that the brainstem has this angle. It's not a vertical structure. It's like this. So if you do a cut, of horizontal cut of the brain, you will get a portion of the brainstem. In this case, a portion of the pons. And here you have the same structure that we mentioned before. Okay, so remember, I don't want all the different thalamic nuclei, just thalamus, and remember that in here you have the body of the caudate, because caudate has head, body, and tail. We are posterior. In here, in the temporal lobe, you will see the inferior horn of the ventricle. The lateral ventricle has an anterior, posterior, and inferior horn. The inferior is in the temporal lobe, and the hippocampus is right there. So we see this hole filled with the CSF and attached the hippocampus. Look here. In here you have CSF. All this is hippocampus, an area that degenerates massively in patients with Alzheimer. That's why there is memory loss. Look here, you can see much better here the ventricle and then the hippocampus. In here, same story. And so you have external capsule, posterior limb, fornix, all those stuff we already discussed. You see new thing, because in this cross section you will see the thalamus. This big nucleus, which is the thalamus. Remember, also in here, it's really very evident, very close to the ventricle, and you will have, look at the corticospinal, how clearly are defined here those fibers. You see all this area? This is the medulla. This is the midbrain. Remember that the midbrain, the corticospinal tract in the midbrain, travel in an area called crus cerebri. You know that is the midbrain because you see the substantia nigra and the red nucleus. And here you have the aqueduct of Sylvius. See, we're reviewing all the stuff that we did. And again, still those structure. You don't see anymore the putamen in here. Also in this, you see a little bit of the brainstem, pretty much the same structure that you see in the other cross section. Okay, what do we see in here? We see the medial geniculate nucleus of thalamus. Remember, medial and lateral geniculate nuclei are part of the auditory and visual pathway. Medial auditory, lateral visual. That's the only nuclei that you need to know. And then here you see the last portion of the caudate, the tail, lateral ventricle, still the hippocampus. This is the pons, and you see the middle cerebellar peduncle. Here you have a mistake, it's not cerebral, it's cerebellar. Here. And here you have the usual structure. Look at this area here. That's the posterior commissure. Again, a little area that connects right and left brain. So anterior commissure, posterior commissure, and corpus callosum. The thalamus, the caudate, lateral and medial geniculate nuclei. Look how evident they are. Visual and auditory pathway. Still a portion of the hippocampus. See, that's not, it's still the same structure. We're getting posterior, so you get a portion of the cerebellum. Look at the fourth ventricle here. the middle cerebellar peduncle, how evident, and then cortex. In here, you will see a portion of the midbrain with the superior and inferior colliculi. And you will see here the pulvinar is another nucleus of thalamus, crus of fornix another component, and another portion of the corpus callosum, and the ventricle. Inside you see the choroid plexuses. In the posterior portion you see the pineal gland. Remember, the pineal gland is the area that the gland that produces and secretes melatonin. Almost done. So pretty much the same structure, much more clear the fourth ventricle in here. You see a portion of the medulla. You see a portion in the midline, which is the vermis, the lateral hemisphere, and if you can look, the dentate nucleus is the biggest, and you can see in here. Remember, it's gray matter. In here we have a cell body of the output for the cerebrocerebellum. The tonsils that are, remember, the lowest portion of the cerebellum. And remember, if you have a tumor or a patient with a stroke in the posterior fossa, the increase in blood pressure can induce tonsillar herniation of the tonsil. So the tonsil will push against the medulla, and the patient will die immediately because of cardiorespiratory arrest, because of reticular formation in there control respiration and cardiac rhythm. And here you can see the nuclei and so on. Okay, so those are the coronal sections. So you see, it's not once you go over and you start to memorize a few, then you see the same structure all over and over. So this is the thing. So remember, regarding the thalamic nuclei, thalamus in general, the only one that I want you to remember are medial and lateral geniculate body, because they are part of two different pathways, and you can have a stroke. You will see that in an MRI, guys. Okay, those structures that I'm showing next week when we do the next lecture, I will show you MRIs. So all this, I have the anatomical slides. On the same anatomical slides, I have the area, the artery that irrorate each component, and then I have the MRI. And then we will have the stroke syndrome. So when you look at that, it will be, everything will be obvious, because you already know in each what is in each area and what's the function. So the stroke syndrome will be very automatic actually for you to build. And I want you to keep all those cross section, because you will use this when you go to the clinics, because it will be very handy. And we will link morphology to function. On horizontal cross section, same thing. You see the same structure, but it's on a different plane. So that part is also very easy. So you will see all the vessel, you see the meninges. So remember, we have the different spaces in here, and remember we have the gyri, interhemispheric fissure. This area here, it's rich in white matter. Remember, it's one of the area in which very likely you will have plaques in patients with multiple sclerosis, centrum semiovalis it's called. Okay, so if you do an MRI in a patient with multiple sclerosis, you will see multiple dots right here, because you have fiber, white matter. So you go down, same story, and then you start to see the ventricle. In the middle you find the corpus callosum, and then you have the lateral ventricle. Anterior minor forceps, those are the different portion of corpus callosum. In posterior major forceps, you see, it's like an X, if you want, structure. The anterior forceps and posterior forceps. Inside, look here, the choroid plexus. Remember, choroid plexus is everywhere, but the largest one is in the lateral ventricle. That's why you produce ventricle mostly in here, and then it flows down. This is very important, because you remember in hydrocephalus you dilate if there is an obstruction the area that is above, because the production comes from the lateral ventricle. Same story in here, with the parieto-occipital sulcus that divide the two lobes. You see here the septum pellucidum. You can see much better that it is a very tiny line of cell that separates the two ventricles, the corpus callosum, the genu, in between frontal lobe, the cingulate gyrus. And here you start to see the basal ganglia, the head of caudate attached to the ventricle, and the putamen more lateral. And this portion here is called splenium of corpus callosum. You see how easy it is, but now you see exactly the localization. Look inside here, how huge are the ventricle, and look at the choroid plexus, how big is the structure. In this cross-section you get also a portion of the third ventricle, that, as you know, it's just in the middle, it's not symmetric. So septum pellucidum, forceps, caudate, putamen, insula, anterior limb of the internal capsule, external capsule because it's the claustrum, same thing. You go lower, and again, portion of corpus callosum. You start to see the lateral ventricle in the temporal lobe. You still have choroid plexus in there. And here you have all the basal ganglia. In this cross section, you can see all the components of the internal capsule. Look here, you have the anterior and posterior. Anterior cognitive, posterior instead posterior the corticospinal tract. So if you have a stroke that damages this portion here, contralateral paralysis. If the stroke is in here, no paralysis. Okay? And you see all the basal ganglia. Look at the thalamus, how big it is. The fornix, all the things that you had before. Again, anterior nucleus, I don't want to know. I want to know just thalamus. Pretty much the same structure also in here. And so all the basal ganglia. And here you can see very well the middle cerebral artery. Also as well, this is the insula. Fornix with a different component. You can see the superior colliculus here, and then choroid plexus in the ventricle. If you go back, you remember that I told you about those optic radiation from thalamus that were reaching occipital cortex? Right here. So you have a stroke here, you have one of those syndrome in which a portion of the field is dark. And in here you can see this interthalamic adhesion. Remember, thalamus from right and left, they touch each other in this area called interthalamic adhesion, and around here you have the third ventricle. Medial and lateral geniculate nucleus. Same story, you get to the third ventricle for symmetric all the way down. Look at the optic radiation all the way to occipital cortex, portion of cerebellum, portion of basal ganglia. In here, we go lower, you see the first portion of the brainstem, the midbrain, the Mickey Mouse area. You have the anterior portion and the posterior. Remember, the anterior portion is the crus cerebri, or cerebral peduncle, corticospinal tract. Then you will have that ventral tegmental area in between that we just described. Then you have the aqueduct, the mammillary body are posterior, substantia nigra, it's right here, this dark spot. And red nucleus, it's right here. You see a portion of the optic tract, lateral ventricle, and you still see the hippocampus. Remember, it's right there. So you see, it's just looking at those structures from a different angle. Third ventricle, optic tract, and the different area that we just discussed. Remember here the amygdala. We're going lower, almost at the pons. You see here the locus ceruleus. Remember the locus ceruleus at the pons, noradrenergic fiber. Aqueduct, cerebral peduncle. Remember, cerebral peduncle or trus cerebri is the same thing. Olfactory tract, and you see the optic nerve in here. You see some artery around here that are very, very important. Go lower and you see a portion of the pons and cerebellum, locus ceruleus, and so on. Lower, the fourth ventricle, and the nuclei. You can see the dentate nucleus is much larger, the vermis is in the middle, and then the peduncle, the middle, that are very evident. Much better in here, fourth ventricle and the nuclei. And here you see the vermis and the pons. And lower you see the medulla, and look here in the anterior portion you have the pyramids. In here, below this, you have a decussation of corticospinal tract. On the sagittal section, same story, different view of the same structure. This portion here, the cortex above the corpus callosum, cingulate gyrus that we mentioned before. Then you have the corpus callosum with a different component. The mammillary body on the bottom, which will continuate with the fornix. Then you have the optic nerve, optic chiasm. Here you have the hypothalamus. This is the thalamus. Posterior you find the pineal gland. Those are those structures that we mentioned before. And just to show where the cingulate gyrus is, we saw that in many structures above corpus callosum. This area is a huge area in cognitive. If you have a lesion in there, you have a cognitive syndrome. Very, very serious cognitive syndrome, and this is an area that doesn't work also in patients with chronic anxiety. And here the same thing, but it's more schematic, so you can see much better. So use this. I'm not going to put this. I just put there for you to facilitate, to identify those structures.